Okay, I think we'll get started. Most everybody's come in from lunch. Hopefully you're all appropriately sleepy and will fall asleep and not have too many questions. So I'm Jim Anderson. I'm the RRC chair. I took over the role from Larry Davis last July. I'm sure he's happy to be sitting in the crowd now instead of up here. And we're going to do the RRC update. Felicia Davis is also here. She'll help answer some questions that I'm unable to answer. We'll be talking about a lot of things. Obviously, we'll spend a little bit of time on the IRDR and the IR residency. That'll be more towards the end, and we'll leave plenty of time for questions. It'll all depend on kind of how quickly I can talk here, because I've got a fair number of slides that hopefully will simplify some things and explain some things that maybe people don't understand. So no conflicts. So we're going to talk about what makes up the RRC in case you're new to the situation. We'll talk a little bit about case logs, the new accreditation system, or the now accreditation system as I like to call it, diagnostic radiology requirements, and then the interventional radiology. So just so you're aware, if you're not already aware, the composition of the RRC has 3 appointing organizations, the ABR, the AMA, and the ACR, and we have 1 resident member. We get nominations from the organizers, and then the RRC selects with the ABR board approving the nominations, and then we also have an ABR ex officio member. It's a 6-year term. The resident member has a 2-year term. The chair and the vice chair are both elected by the RRC within our group. The chair's term is 3 years, and the vice chair has a 2-year term. We have a pretty good distribution across the country for current members. This is our current committee membership. We represent all the different subspecialties, and Dwayne Meswa is the vice chair. There's a couple new members that will be coming on this July. We have a new public member. The ACGME board had recommended all review committees have a public member. That's becoming more common. And so we've done that, and Jennifer Bosma, who used to work at the ABR, has been selected and will begin this year with us. So that'll be nice to have a public member. She'll be functioning as a full-fledged RRC member, performing all the same duties and tasks that we do on the RRC. The other new addition that'll start in July is one of the DO with the single accreditation system. We need to add a DO member onto the, or an AOA member onto the accreditation system. So George Urbacher from Oklahoma State will be joining us as well, and again functioning as a full-fledged member. We'll talk a little bit more about the single accreditation system and the AOA entry into that in a minute. So again, we're into the next accreditation system now, so they're going to have to change the name probably eventually because we're in it now. We've been doing it for several years. Hopefully those changes have gone relatively smoothly. We're starting to work into the self-study portion of this. Some programs have already been notified that they're eligible for preliminary steps in the self-study process and the 10-year site visit. And many more programs will start to come online with that over the next several years. A lot of that information is on the website, the ACGME website, and so I'm not going to talk too much about that. But just to remind everyone, the whole idea behind the new accreditation system is to review programs on their outcomes and educational milestones on a yearly basis, essentially. Instead of doing the a credit for at one point in time and then move on 5 years and then reaccredit, is you just kind of update us each year and we review all programs each year. It helps poor programs or programs that are performing poorly to improve. That's the main goal of the NAS. And to allow programs that are in good accreditation to innovate. So if you're in good standing, you're allowed to have some leeway in how you fulfill the requirements. The annual update that we review as the RRC includes a lot of different data, most of which you enter into the ADS each year. We also get board pass rates from the ABR. We receive the resident survey and the faculty survey from your institution. The clinical experience of case logs is reviewed. The milestones, since they've just begun, have just started to be implemented, so we're determining how we're going to implement the milestones into the review process. And then, of course, since the 10-year site visits haven't occurred yet, we haven't actually started using that, but once that information comes on board, we'll have the self-study and 10-year site review information to review programs as well. So again, our role as the RRC is to really concentrate our efforts on programs with problems. What we want to do is kind of detect places that are having difficulties, either through the surveys or through your data that we review, and give you advice basically on how to improve that. Rather than acting more as a police force like it was in the past where we're citing everything, we can give areas of improvement as kind of a first warning that things might not be going as well for you if you aren't aware of it already. And the one way I kind of always think about this is really we're trying to encourage all the programs to do what they're supposed to be doing anyway, which is annually reviewing your own program and assessing it for what's working and what's not working and making changes and seeing if those work. And really the whole NAS system is designed around trying to make each program perform that role, which you're supposed to be doing anyway. If you are in non-compliance with the program requirements, you can get citations, and those will happen. And then we also try and get the citations off the plate quicker. So before, where you'd have a citation sit on your record for 5 years until the next review, we now review that information yearly. And so if you have a citation, you respond to it, it looks like it's cleared up, it gets off your record right away. So you aren't carrying citations as long. Hopefully we do provide useful feedback for improvement, the AFIs that you may receive if you are having some area of difficulty. So take those with the intent that they're sent to you with, which isn't a slap, it's really more of a prod to try and do better. So it's really a motivation method rather than a punishment method. We are still seeing some things on the RRC level with responses to citations that do exist. I think that's really important for all the program directors to understand that we take this seriously, and you should too. If we're sending you an actual citation and we're asking for a response, that it needs to be a somewhat robust and well thought out response. We're not able to assess things if we don't get that kind of response, and so it's hard to remove a citation if you send us back information that really doesn't address the problem, or if you just say, yeah, we know about this and we took care of it. That's not going to really hold water. So you really need to put some effort into the response to the citation and let us know what you're doing to improve or fix the problem that we've identified. In the absence of that, we can be forced into sending a kind of a selected site visit to find out what's going on ourselves. So if you want to avoid that, try and give us a good, complete response. The other real area that we're still having a lot of problems with is the case log, what we consider inaccuracies. It's a little hard to assess, but we've had enough time now that we've tracked entire residency classes that have had data entered into it, and we're getting some really unusual numbers. So there's at least one resident out there that over their 4 years read 26,000 chest exams. Documented in the case logs. That is a lot. You guys, I've done the math, and I won't repeat it here for you, but if you do the math yourself, you'll realize just how many, if they only did 4 rotations, 4 months of chest in their years, that would be a pretty significant number of chest x-rays each day. So, and there's also some very low numbers, zeros. So we've got people that have read 0 studies in certain areas over 4 years, and that seems probably not what we want to have happen. If that's accurate, that's really bad, and if it's inaccurate, then that needs to be fixed. One of the requirements is for the program director to assess and review that for accuracy. If a program director isn't seeing that there's a 0 in there and assessing for that accuracy, they can be technically cited for that because we're kind of assuming that isn't accurate. I guess we could say that, you know, that's an area for improvement. You could respond with, no, actually that resident actually only read 0 studies. Then we might have to cite you for that. So there's really no way around that one. So we think that data errors are still being recorded. But you want to make sure, we've had enough time now, that your system should be in place where you have at least a reasonably good assessment of the case logs. And we know it's somewhat difficult. I've been through it too. I'm a program director. Every year I have to go through and make sure it's accurate. But it's just something we have to do because we do want these numbers to accurately reflect the experiences that the residents are having. Here's just a sample of some of the stuff that we're getting. So here's that chest x-ray with actually 26,500, so even more. And then we have a lot of minimums. So someone's read 0 brain MRIs. So that's not very good. I'm wondering how that resident's going to go out and practice. So we feel like these are probably inaccurate numbers, but we really don't know, and we really hope that that's not a resident's experience. Mammography is a real problem because you need to read a certain number in order to qualify. One mammography in 4 years is not going to qualify you to read mammos in the future, nor would any of these 2%. So 2% of the residents out there probably are not qualified to read mammography. Unless you've got some other system that's assessing their numbers, but then why aren't you using that to enter your case logs? So, chest x-rays, which is another one that we see huge numbers, we also see extremely low numbers. So 300 exams is not really probably quite enough chest x-ray experience. And we're not saying that, the case logs are not there to say that you need X number to be qualified. I mean, maybe somebody is a brilliant chest resident and could read 300 and feel like they've had a full experience and able to do it, but I would say that if I surveyed the room, most people would probably not agree with that statement. So we know that some of the difficulties are with the CPT code changes that occur each year. We try to assess that. We've just gone to a system where we're working with SIR and ACR, which have pretty robust code tracking methods in or groups in their organizations. So we're going to be working with them in the future. We've started working with them in order to assess the code changes each year and get those updated as quickly as possible. A few of the things that we've changed here recently and are being changed in the system right now are the ones that are listed. And so once these are all in the system, you should be able to start entering your case log data accurately if you have the right CPT codes. I think this collaboration with SIR and ACR will be a big help for us to keep up to date with that on a more timely basis. So program requirements. There's one new rule that we need to talk about a little bit. So the new eligibility requirements, which take effect July 1st, 2016, have become relevant because the people we just matched are that group. If it's the advanced position. And so the rules as the ACGME has them written are the prerequisite, there has to be prerequisite ACGME training or the equivalent in the Canadian system, clinical training prior to residency, and prior to fellowship you need prerequisite ACGME residency. There are some exceptions by subspecialty for the fellowship, we'll get to that in a second. So we are allowing some exceptions. But for the first part of this, for the residency, there really are no exceptions for that. However, given the match that had just occurred and numerous inquiries to us at ACGME and some problems that we've heard reported of people that thought they had eligible clinical year experience before they matched and now do not have appropriate ACGME accredited, we're going to have a temporary rule for the year 2016 that will allow programs that have accepted residents with either documented clinical training in their home country, so foreign medical graduates that have done some kind of clinical training in their home country, if that's documented, or if they have already enrolled or going to be enrolled in an ACGME accredited radiology fellowship year prior to entering into their residency. Those will both be sort of allowed as long as you notify us of those particular circumstances at your institution. This is a one-year transitional rule. We aren't the only program that's doing this. Several others. We feel like we probably didn't have the word out strong enough prior to this year's match to allow everyone to fully understand these rules. Even though they've been published for a while, they hadn't been really explained or stressed. However, this is the stress message that next year there are no exceptions and that won't be changed. So beginning July 2017, you need to have your people have accredited fellow or clinical year prior to entering your residency. So when you're assessing your candidates next year, make sure that if they're foreign medical grads or some other unusual situation that they've already established that or are going to establish that and are in the match to attempt to obtain one of the preliminary years. Or you take them in as a C candidate, a categorical candidate, and train them yourselves in an approved program. So that's what you need to do. For those people that are that we've been hearing about, that are the candidates from the U.S. that have not yet obtained a preliminary year, this rule, the exception rule doesn't really totally apply to them because they don't have any clinical experience outside of the U.S. They don't have a fellowship established yet, so they're still in a little bit of a situation, and we're trying to find out more information from NRMP as to what that problem degree is, and we're hoping to get some more information about that soon that we can distribute. For the fellowships, basically, because there is the exception rule at your own institution where you can apply for an exceptional candidate, we don't really apply this temporary rule for the residency to the fellowships because in a way there's already a method around it if they don't have a ACGME residency already established. So if you've taken a fellow or are taking, I guess the match is still going on, so if you're taking a neuro or IR fellow or something like that that hasn't had a ACGME accredited DR residency, you would need to apply for the exception. So you're in a little bit of a situation right now where you need to kind of see if that can happen prior to them matching, because after the match you're kind of stuck one way or the other. The other thing that's going on with the program requirements is there's a major revision. So amongst all the other changes that you're facing, the RRC is also facing that we have to go through and totally revise and review the DR program requirements. This has already begun. We've sent out notifications to interested groups to have early input into the process. The whole process will take 12 to 18 months, could take longer. We'll see how it goes. So basically the steps are we request input from different parties. Anyone that has input into that can either let their own organizations know, so like APDR, ACR, ABR, all those have been notified. We'll have draft revisions. It's going to be a fairly major revision in the sense that we're going to go through everything and really see what needs to be there and what doesn't need to be there. It's been a long time since the DR program requirements have really had a thorough cleaning out, and so there's a lot of debris in there, as you're probably aware, that has been left over and doesn't really mean anything anymore. So we're going to try and get rid of the things that don't mean anything and make the program requirements follow along with the kind of new accreditation system idea of outcomes so that we can assess the outcomes rather than the processes. So we'll have after we do the draft revisions, there'll be a review and comment period. It'll be posted on the ACGME website. We'll evaluate those comments. We'll make responses to those comments. We'll do a final draft, and then it goes through the RRC and then through the executive board at the ACR for final approval. So that whole process will take probably a year and a half. It could take up to 2 years, but we're hoping to move along pretty quickly on it. Some of the things that we already know we're going to have to consider is the integration with the IR residency program requirements. So it's very likely those will get changed in tandem with our DARC because some of them overlap and they need to be well coordinated. We want to align ourselves with the ABR testing process, which isn't necessarily written into the current rules the way the program requirements are written, so we want to align that a little better. We have to take into account the AOA membership and the single accreditation system that's being established at ACGME. And we do want this to be more outcomes-based rather than prescriptive language for what you all have to do. Tenure site visit and self-study is basically an improvement program. And I'm not going to talk too much about it because, again, it's been changing a little bit lately at the ACGME level. And some notifications have already gone out, and we don't want to have contradictory information in case we don't know exactly the same language to use. So it is a comprehensive review of a program. We want to see how you make an effective learning and working environment, how it leads to the outcomes that we want to achieve, and an analysis of the strengths, weaknesses, opportunities, and threats for improvement. So it's basically just, really evaluation that you should be doing on a yearly basis, but at a more robust level. I mean, every year you should be looking at your program and saying what's working, what's not working, what can we improve, those kind of things. This is just a little more robust. So we're going to allow some time between the self-study and when the actual site visit occurs. So you get that time lag so you can actually do your self-study and assess it and get some improvements in place before the site visit. So in a way, we're giving you a chance to look at your program, give you some time to actually make some changes and implement those things, and then we'll have the site visit that looks at your whole program. So you really should be well prepared. It's a little bit different. You had a lot shorter time period in the old system. This gives you a lot more time to actually implement some changes. So we're hoping people can actually have robust, well thought out changes in place before the site visitors get there. There are some voluntary pilots that are ongoing now. Those places have been already, if they're eligible, they've already been notified, and that's really all I'm going to say about that. For the single accreditation system, this is the infolding of the AOA with ACGME. And why we're doing this is we want a consistent evaluation and accountability for all the radiology training, well, for all ACGME training periods, residency training, but for us specifically for radiology. We want to enhance the opportunities for trainees so that there's more opportunities both from the medical school side and from the AOA side. Eliminate unnecessary duplication and hopefully create some efficiencies with the accreditation system. There will be a new committee at the ACGME level, the Osteopathic Principles Committee, 17 members. They'll have a chair sit with the rest of the chairs on that committee. The accreditation in the new system will basically, there's kind of a transition period, and I don't want to actually go into this too much. If you have questions about it, we can probably explain it in person a little better, but basically they'll get kind of an initial accreditation. They have to show that they're in substantial compliance with the program requirements, and then that window for that application closes probably June 30th, 2020, and then people will move from initial accreditation on to full accreditation, hopefully during that time period. That's kind of repeat. So the pre-accreditation status is something special for this new system. It's extended to the institutions, and as they get this pre-accreditation status for applying, then they'll be able to move into initial. They're not equivalent statements, so a pre-accreditation is not an initial accreditation. So what's this mean for radiology? This is really the slide that's important. There's about 13, 15 AOA DR programs out there. We're going to add the one committee member. We'll have to review and site visit all of those programs to get them up and running and get them into the system, and we anticipate we may review those as early as spring next year, but we'll see kind of how that whole process goes. There's a lot of different moving parts to that. All right. Okay, so interventional radiology, the topic everybody's waiting for. So what I'm going to hope to do here, so I've been involved with this development since I joined the RRC, because that's basically about the same time that they approved us to move forward with forming a new training program for interventional radiology. So it had already been basically through all the processes to approve it prior to when I took over. So I feel like my role and my role currently is basically we have to implement this. It's out of the box, and we have to figure out a way to make it happen. And my background is not interventional, so I wanted to definitely be a part of it so that the non-interventional side was represented in this whole thing, and try and get a balance between the DR and the IR components in order to get a system that would work for everyone. So you've heard this many times. It's just my one slide as to why we're doing it. The belief is that it's fundamentally changed over the past 10 to 20 years. It's now a clinical specialty. I always cringe at the word clinical because I think we're all clinicians, but that's all right. It's been acknowledged by the ABMS. The ABR has certified it as a new certification, and the ACGME has determined that we need a program to train this in. So we're at that point, and we started to develop the program requirements over the next couple of years, and those were finally approved September 2014. And so there's still a lot to do after the program requirements are approved. But really, it is time to get started. And for programs that are thinking about doing this, you really do need to understand the system to some level, hopefully in fairly good detail. It is super complex. I have no doubt about that. But it is understandable. And I'm going to try and go through some parts of it and hopefully answer questions and be able to clarify some of the misconceptions, the misinformation, and just make things a little more clear. So we already have the program application and the FAQs posted on the ACGME website. So you can learn a fair amount from that about what needs to occur in the interventional training pathway. We're still working on some case log information as to what information we're going to require for that, and procedure log information for the IR procedures, and the milestones will have to be changed because they can't totally use the fellowship milestones, although they'll probably be somewhat similar. They're going to have to be redone, and a new committee will be formed to have that. We have a little bit of time to get that going. The key components of IR residency as compared to the current IR fellowship, it's really an increase in the number and breadth of procedures. So that basically requires more than one clinical year or more than 1 year of training. That's kind of one of the fundamental beliefs, that you can't get the training in one single year. There's clinical care that's required in the new IR world, so critical care rotations and outpatient clinical experience and inpatient consultation experience needs to occur. So those are really the things that are different at a fundamental level from the current fellowship. There's 2 pathways that were developed. These use the model that some of the surgery specialties use. So there's an integrated residency, which I sometimes refer to as a 5-year pathway because it's otherwise integrated, independent, get confusing. So there's a clinical intern year. You can do it in anything. The IR people suggest you do it in surgery, but it's not mandated. And then 5 years of interventional training. As people have said that you've heard before, 3 of those are essentially equivalent to the diagnostic radiology current program requirements. And then the 2 years or more interventionally intensive, with the final year for sure being completely interventional. The independent residency is established so that there's a 2-year IR residency, and you need to complete a DR residency before you can move on to that, including the clinical year prior to that training. So those are the 2 basic pathways. The key facts from the integrated program, you'll be able to match from medical school into the PGY2 program. You could have your own intern year and match to that as well. It's a 5-year program. The first 3 years are diagnostic radiology training. You still take the ABR core exam after 36 months of radiology training. 2 years, the last 2 years are primarily in interventional radiology, but there are some allowances for diagnostic radiology rotations that are needed. So that you can get mammography numbers, you can get nuclear medicine months in, things like that, call rotations. It does qualify for the ABR IRDR certificate. That PGY 5-year, which is sometimes confusing, so I call it the DR 4-year. It's also equivalent to what would be considered the IR integrated 4-year. Can have some DR components, so call, float, mammography, nuclear medicine. You can pretty much make up what needs to occur that year as long as you allow a certain amount of interventional experience during that year, and we'll talk a little bit more about that. Rotations can be in the interventional domain, so there's a document that SIR has published that basically describes what the domain that is included in the interventional radiology domain. So you can have rotations that aren't necessarily in the interventional suite or to have to do with vascular interventional, They may be done in your body section, but you're doing lots of procedures. Those are still potentially in the interventional domain, and those can be considered part of that training. And I'll talk about that a little bit more. And then there has to be procedure and patient, those rotations have to be procedure and patient care oriented. The independent program is much simpler. It's just 2 years. You finish your radiology residency, there'll be a match, just like there is for the fellowship currently. It'll occur during the DR3 or PGY 4 year. At least that's the discussion right now. It's possible that could get changed, but assume that for now. You'll match to the 2-year program afterwards, and if we just left it at that, that would have been it. And frankly, that probably could have worked, but it would have alienated and caused a lot of problems for a lot of different programs. So fairly late in the phase of development of the program requirements, not too long before we had approval, we needed to, one of the key components that we wanted to do was if someone decided they wanted to go into interventional sometime during their radiology training, how would they get into that pathway without extending their training an extra year? Is there a way we can do that? Well, there are programs that have kind of a 3-2 method. So you do the 3 years of diagnostic, you do a pretty substantial mini fellowship. In interventional, your 4th year, and then you go into your 1-year fellowship. So ESIR essentially replicates that system. It's part of the DR program. It's not part of the IR program. So DR programs are in charge of it. It's a curriculum that establishes equivalent training compared to what would be the R4 or interventional 4-year on the integrated pathway, or also equivalent to what would be the first year of the 2-year independent pathway. So those 3 are kind of equivalent training time periods. And so if you think about setting up an ESIR, you want to think about trying to establish it in as similar a pattern as you can. If you have an interventional residency, you want it similar to either your 1st year independent pathway or your 4th year integrated pathway. It takes advantage of that R4 year flexibility that's built into the system with the ABR testing methods. We have to have that curriculum approved because we don't want everybody just making up whatever they want to make up. So we'll have a subcommittee that reviews applications for the ESIR curriculum and make sure that you have the resources you need for that. And I'll talk about that in detail here in a minute. What this basically allows you to do is if you get this ESIR approval, you send a resident through that curriculum, that when they match, you've approved them sometime in their 3rd year. They match to a program that has a 2-year independent interventional residency. Then they would be allowed to enter into the 2nd of those 2 years. So essentially a 1-4-1 process, 1 year of clinical, 4 years of radiology training in a diagnostic program, with that last year of that being largely interventional, and then a 1-year extra year of doing interventional in an independent program. So I think that's what I just said. So when you apply, there's no site visit. So it's not an application in the sense of starting a new program. It's a paper application with some documents you need to send in. We'll review that. You can do it whether you have an interventional radiology residency or not. So whether you have an integrated program, an independent program, both, or neither, you can still apply for ESIR. As long as you have a diagnostic radiology program, you can potentially have an ESIR curriculum within it. What is required is that the DR programs specify the training. It actually encompasses all of 4 years. Now the first 3 years are probably going to be what you're already training your residents in for interventional, but you could add extra, if you're a program that's able to do that, you could add extra interventional type or interventional rotations in those first 3 years, and then you wouldn't have to have quite as many in your 4th year. So that's one option, or you can have it all largely be in the 4th year. You need to verify that residents have received that training. So if you had a resident that got sick or had something else happen and couldn't actually complete the ESIR training, you would have to let the program that they've matched to know that information. And you'll have to have adequate facilities and personnel to provide that fundamental level of interventional training. So, again, if you've already got an interventional program in place, you probably do. For programs that don't have a fellowship already established, you need to look at your capability of training interventionalists and see if you can actually provide enough resources for them to get the experience that they need. This is kind of what the application has said. This is not published on the website yet. We actually held it off from putting it up because we wanted to hear some feedback this week to see if there was anything that we needed to adjust or that was too onerous or didn't actually meet the needs of everyone. But this will basically be what the application consists of: a letter of support, a description of how you select your residents, because we want that to be transparent, a block diagram showing what your curriculum is. You'll need we'll have a spreadsheet or a table that you fill out with the categories of planned procedural experiences so we can kind of see the breadth of experiences that you're able to give residents. An estimate of the total volumes of interventional procedures. You need 500 to qualify to get into that advanced position. You need an attestation from the IR section that it's providing the clinical care in the settings that are required, so ideally in a clinical setting or an inpatient consultation, and the list of IR faculty, which you, of course, should already have. So just a little more detail. The letter of support shows that the DIO, the chair, the radiology program director, and the interventional director know about this system and are all in support of it. The selection process, again, we don't want residents to kind of be blindsided or have this be sort of random. We want you to establish the criteria that you're going to use to select what residents you're going to put into an ESIR curriculum so that they have some idea of that in advance. The block diagram, you give block diagrams now for all the DR years, so you really just need to indicate how that's going to change for your ESIR curriculum within those 4 years, highlighting that you must have at least 12 rotations. Rotations are defined as 4 weeks in IR, or what we call in IR-related areas. I'll talk about that in a second. You can have more than 12 if you have that capability. I'm not sure too many people will, but you can have up to 16. You need at least 8 what we consider IR rotations, so kind of run by the interventional service in the interventional suite that are substantially the interventional rotations, and then you can have up to the rest of them, the other 4 or so, can be in kind of IR-related areas. You need to have at least 1 rotation, 4 weeks of a critical care rotation, SICU, ICU type rotation. So that's something you might need to establish. Here's an example of a mythical program block diagram. And it shows the highlighted yellow shows that the first 3 years they each get 4 weeks of interventional experience, and then a mix of what we consider interventional rotations that are part of the ESIR curriculum. Something like a neurointerventional would qualify. You could have something like a musculoskeletal procedure rotation where the resident is largely doing patient care and procedural experience. It doesn't mean they have to do that 100% of the time, but that should be a substantial portion of the rotation, and it should be the educational intent of that rotation. You could have a body procedure, a CT or ultrasound guided procedural rotation, because we know that out there are as many different types of rotations as there are programs. So everyone does things a little differently. Some people have procedure rotations, some people have some procedures done by body people, some people have procedures done by musculoskeletal. So how you define that needs to be a little bit flexible. So we're allowing quite a bit of flexibility with those kind of rotations. They will be reviewed to see if they kind of meet what we're calling the litmus test of whether or not they qualify for kind of interventional training. And then you need to have some kind of ICU experience in that too. This is a typical block diagram with 13 rotations per year, 4-week rotation blocks. But some of them have 6, some of them have 2, that's all allowed. If you run a 12 rotation block schedule, it's essentially equivalent, but you kind of lose a little bit because you don't have as much flexibility in the timing, but that's something for you to work out. For the IR-related rotations, you need to give, so all rotations need goals and objectives. That's part of the program requirements. You need to have those competency-based. So you'll need to develop those for any new rotations or rotations that fit into this curriculum. But for the application, at least, you can simplify those to some extent. You don't have to give your full competency-based goals and objectives. You can give really more why this is an interventional or interventional-related rotation and explain what the experience is going to be and what the expectations are going to be. You also need to give kind of the number and type of IR procedures expected. Again, we can't know that in advance, so you kind of give, if you have one person on the rotation, you'd expect, you know, so many biopsies. If you have a rotation that's got 2 people on it, you know, you'd have less, things like that. Again, the table with categories of procedural experience that would constitute the resident's experience, the volume. It's the total volume over the 4 years. So any rotation that has this type of procedural activity would add up to that 500 minimum that's required. So that's a very broad number. Probably what it'll come down to is we'll have certain criteria about the procedural expectations and what categories of procedures you have, so you have some breadth as well. That's the last kind of part that needs to kind of be established, and we hope to have that done pretty soon. Again, this attestation that you're providing clinical services, clinical care in the form of either outpatient clinics or follow-up clinics or something along those lines, as well as inpatient consultations. I think most places that have interventional programs, fellowships, already have this established. If you don't have a fellowship, you may or may not already have these kind of clinical experiences established, and you may have to think about developing that. But it should be something that's you're capable of doing, we hope. And then faculty qualifications, you basically just have to list them and why they're qualified to teach interventional, whether they're interventional trained with a fellowship and CAQ'd. But there are also people out there we know that have done procedures their whole life and do them every day and are well trained in how to do procedures and take care of patients around procedures. So those people, if you can attest as to why they are qualified, those would count for people that can be in charge or in training the residents for these rotations. There's a lot of terminology that people throw around and get very confused on. Probably the number one is just has to do with time in general. So when we talk about dates and things like that, people get very confused. So I'll try to, as I go through like timelines, I'll try to be very clear about what I'm talking about. But at the basic level, we're just defining a rotation as 4 weeks. It can be a month. It can be two-week blocks that are, you know, have to do with the same thing. It can be 6 weeks. And that would count as like 1.5 rotations. So, you know, we're being pretty flexible at how we establish what a rotation is. We're letting, because we know there are programs that run 2-week blocks. We know there are programs that run 8-week blocks. So rotation doesn't mean too much when you have all sorts of different systems. So again, weeks is kind of the minimum block. We try not to have any 1-week blocks. But to talk about all these rotations in the sense of weeks gets a bit cumbersome, which is why we're using the term rotation. So rotation, 4 weeks. Can add them up. And then the terminology for what's an IR rotation and what's an IR-related rotation. This is language that's in the program requirements. There's some FAQs that talk about this a little bit as well, so if I don't fully explain it, that might help. But basically an IR rotation are rotations that occur in the IR section. Every residency has some kind of IR section, or an IR suite, or under the direction of an IR certified faculty. So someone that's been CAQ'd in IR, those are all basically considered IR rotations. Because basically the idea is that if it's people that have been trained in IR and CAQ'd in IR, then they should know what the expectations for that training is. And so that counts as an IR rotation. IR-related rotations are ones that occur outside of that realm. So they may be procedural, but they may not be done by people that are CAQ'd with IR. but have plenty of experience with teaching it. So rotations, like I mentioned earlier, musculoskeletal rotations that largely do biopsies and other musculoskeletal procedures, neurointerventional, either chest or body or ultrasound. All those are potential rotations that could be very procedurally oriented. And it may be that you have a rotation already set up that's you call CT or whatever, and they do procedures and they read abdominal CTs. And you're going, well, is that a procedural rotation or not? Well, it's the intent of the procedure or of the rotation. If it's to read CT scans and occasionally do a procedure, then that's a DR rotation. If it's primarily to work up, assess, do the procedure on, and follow up the patients that you're doing the procedure on, then that kind of falls into the realm of an IR-related rotation. And you can set up goals and objectives separately. You may have someone on the same named rotation, but one rotation will be DR-oriented and one rotation will be IR-related oriented. And you can kind of decide how you want to put your residents in there. But it doesn't mean that an IR-related resident on that rotation can't read an occasional CT scan. So there's some flexibility in that. The other terminology that's extremely confusing are these basically ones, and some of them you may haven't heard of before. Complement, everyone knows pretty much what that is, although there's a lot of misconceptions about it. So basically it's the ACGME word for how many residents we've approved for you. I'll talk about that in a second. It actually doesn't have anything to do with how many positions you have. I mean, if you have funded positions for less than your complement, you can have a complement of 20 and only 16 residents. If your institution will let you hang that way for a while, that's fine. Some will take your money away eventually. But so those are two independent things. They may be related because you may only be able to have the complement of your funding, or you may not be able to get more complement than your funding, but they're actually two different numbers. Training capacity is a kind of a new concept that we came up with to help understand this. And what you really want to think about is how many residents can you train in DR or IR. So there's a certain capacity that you have both in sheer numbers and breadth of experience in IR. And right now you may have 4 interventional fellows, and you can train, you have enough numbers of people, you have enough resources, you have enough cases that you could have actually trained 8, but you only have 4 fellows. So your capacity is 8, even though your fellows, you only have 4. Hopefully the capacity is never under the number of trainees you have, although there's probably programs that push that limit pretty tight. But the idea is you have to figure out what your training capacity is. That's based on your total volume of studies, it's based on your breadth of cases, it's based on the number of faculty you have. It's based on the resources, how many rooms you have. Maybe you can only have 1 room. How can you train, 6 people at that same time? So all these things have to be thought of when you think about training capacity. And then match quota, of course, is an independent number as well. I mean, you can change how many people you take each year. You can change the match quota each year. So that can vary. This is just an explanation of complement. Remember, it's not a year by year. A lot of people say, oh, we take 6 a year, like that's their complement. But complement is really the 4 years added all together. And you can have that in any number that you want. Most people like to have an even number every year, but lots of us don't for various reasons. And the complement is a maximum. That's the maximum number of residents the ACGME will allow you to have, because that's all you've been approved for, unless you apply for an increase, either temporary or permanent. You can always have less than the complement. You don't have to ask for a decrease in complement if you don't fill your residency. Most people don't want to run under for both workforce reasons and because funding may be removed from you, but you can technically have less than the complement. Complement's potentially determined by training capacity, but at least in DR, I think most places probably have way more capacity to train than they have number of residents, so I don't think that's the limiting factor for most people. Sometimes it is faculty. There are a few programs that are butting up against how many faculty they have versus how many trainees, and that gets to be an issue. Or again, other resources, which could be money, space, time, all those kind of things can limit your complement because your training capacity is reached. This slide kind of explains the whole idea behind training capacity. And basically, the shading indicates that even when in the current situation you have some component of DR training that is IR related. So the rotations that your residents rotate through has some percentage of time. And then in their 4th year, their DR 4 year, some programs may have more. So you may actually have more fellowship training in the DR year for a certain number of your residents. So your training capacity is actually all the blue here plus the fellows to indicate your training capacity. This is why DR complement, in a way, if you just consider your DR component and not the IR, you're actually always slightly under training capacity because you probably figure that that's a whole person, but in this realm, at least when we're thinking about it this way, you're not really. So right now, your training, your DR complement is technically considered your training capacity, although you may actually have more. This is what happens if you're a program that has both an interventional or an integrated and an independent program. So again, these 3 years are equivalent. Whatever percentage of time that your residents are spending in interventional, these 3 people will spend there as well. Same as these 3 years. So your training capacity is however much you provide here in IR and all this, and then basically all the other blue here. So that's how you can kind of figure out your training capacity. But your complement is still based on how many DR residents you're allowed, how many integrated. There'll be a complement number for integrated, and there'll be a complement number for independent. And the idea is, again, because those can potentially be higher than however many people you have in, you should have some ability to wiggle back and forth if you need to and fill independent slots if you don't have enough integrated people in your system. And that allows you some flexibility to do that. Now, I understand that at a local level there are different challenges with doing that and explaining that to your DIO and explaining that to your GME office, and I can explain some ways to potentially do that, but we'll get to that maybe in questions or something. If you had an ESIR resident in, you'd have to consider how much time they're going to spend in the interventional realm and add that into your IR training capacity. So you could have this situation where all the people here, except for a little bit of the 4-year, and then a lot of this DR resident that's doing ESIR are all going to be. So you could easily outstrip your training capacity if you're not aware of what that is. If you just run an independent program, basically this is your situation. And if you have an ESIR, what will largely happen if you can always match ESIR residents is this one gets eliminated and you match someone from some program that's done ESIR into this program. And so your capacity is whatever number of people you have in either of these 2 years or both. And if you have an ESIR person at your institution, then that portion of your IR experience for your training capacity. So to me, that's a really important idea or concept to figure out, because the big concern, you'll have a complement and the ability to bring in potentially more IR trainees than you could ever possibly train. And that could have effects on the DR residents, and we don't want to have that kind of a situation occur. All right, so what do we do now? Well, the big thing is there's no single solution. We've run through pretty much as many different scenarios as we can think of. We've actually looked at programs, their numbers, how many fellows they have, how many they think they want to switch to integrated, how many they want to switch to an independent. Jean LaBerge, who's done a tremendous amount of work on this, and I have spent countless hours trying to figure out how not to hurt anybody. And in all of this, we think we've come up with a system that's flexible enough that if you can explain it at your local level as to why you need to do this, because your fellowship's going away, and why as a DR program you need, if you don't have a fellowship, why ESIR is in your best interest, and you can work out the local problems with that, then I think we've given you a system that's very flexible that you can do this. It's complex, but if you get it down to your own place and ask the right questions, most of the time we can figure out a solution. We're going to have a mentorship system that we're going to be starting to build now that will help people do that. We're going to get more and more people that have the knowledge base of all the different ramifications so that you can call or meet with people and get that information. That's not set up yet, but we'll let you know when that is. There's basically two scenarios. You want to have an IR residency. Whether you have a fellowship or you don't have a fellowship, you can establish one now. Or, I don't want to have an IR residency. I don't have a fellowship and I don't want to have a residency. If you already have a fellowship, that means giving up your fellowship and having nothing to replace it. If you want to do that, that's fine. If you don't have an IR fellowship, then you just don't have to do anything necessarily. Like I said, local issues are a big part of this. You need to know your funding. You need to get local GME approval. There are departmental issues and concerns that you'll have to address. You have to know your capacity. You want to know what your IR residency structure is going to look like. And then you're going to want to educate the decision makers, your chairman, your DIO, your GME office. You need to educate them as to why this is needed and why it may not fit in their little box of what they consider the world exists of. Because it's a different scenario. There aren't very many times any GME office has ever faced the removal of a fellowship and the institution of a residency. So this is a unique experience to them, and they aren't necessarily going to understand what is involved. So you have to know what your components are, where your funding comes from, those kind of things. They're going to want to know those kind of information. You're going to want to be educated so you can educate them. And then ultimately, once you get them educated and they approve it, they'll release the application. They have to release it so you can start applying. You go to the ACGME website and you get the application and you start filling it out. You'll have to work with your DR program director as well in order to make that happen, especially if you're an integrated program. But even in the absence of integrated, if you're an independent, it'll still take some collaboration. If you want an IR residency, you can do integrated alone. We're highly recommending for the most flexibility that you at least apply for both. If you don't need your independent down the road, you can always let that part drop. But we're kind of giving you a free pass on the independent. If you apply for the integrated, we'll site visit you, we'll get you approved, and then we'll activate your independent program with just a review of the information or an update of the information at the point in time the independent programs come online. Or you can run an independent only, and all of those can have an ESIR or not, depending on whether you want to do that. If you don't want or somehow can't support an IR residency, you can do nothing. Nobody's forcing you to do anything in this situation. You can still have DR residents. They can finish. They can go do an IR residency. It'll take them one extra year, but they can still do it. You're not stopping them. There may be some advantages, disadvantages in your local place to do that, but it's an option. Or you can develop the ESIR curriculum, which gives you the chance to shorten their timeline and let that resident get out and have 1 year of kind of additional training after their residency. If you have a program that has robust IR experience but no fellowship, you probably can provide that experience, give them the training they need to get into that 1 year post-diagnostic residency training. For that, you basically just need to know your capacity and apply with the documents that I talked about earlier. People often ask, what's this mean for the trainees? Again, we've gone through almost every scenario. I don't expect you to read this slide. I've got a whole nother talk that just basically walks through everybody from the current residents and all of the different years all the way back to people that haven't even entered medical school yet, because the timeline is that long. So for anyone that's in residency right now, essentially nothing changes. They're all going to probably do a fellowship. Now, there might be some programs that have integrated programs that they could transfer internally into the integrated residency, and there may be reasons to do that. There may be reasons not to do that locally. So again, you kind of have to make those decisions. I took out a couple. So the current group that just matched, the MS4s that just matched, will be interns in the 2015-16 academic year. When they hit an R2, this is the year we potentially will have a fair number of integrated programs active. They could potentially internally transfer. There's really no good reason to transfer as a second year. You just as well wait till you're further along. Whoops. So you could transfer in the R3, or most likely people will transfer into the R4 year depending on some local factors. So this would be one pathway. They could get into your residency as they are now. They could internally transfer at some point, most likely R4, and they would be in the integrated residency at your institution for the R5 year, and they would finish. Same as a fellowship. Except they'd get more experience because this year would be under the IR residency direction. The other option is they don't internally transfer because you either don't have a program or they don't want to. They want to go somewhere else. In the R3 year, they'll have an independent match in the year 18-19. So the match will probably occur sometime in the spring of 19. And then they will match for the year 20, which will be the first year that the IR independent residency exists. And they could match into the first year if they don't have an ESIR and do a 2-year residency. Or if you have an ESIR at your institution, they would match into the second year of that training, and they would finish at the same timeline as this person. The other group that I pulled out to kind of give an example of are the current MS2s, the ones that are right now, MS2s, MS3s in July. They will hit the match year 2016-17, which should be the first integrated match. So they can match to DR just like they would now, and they have all the same options that I just outlined. So they can internally transfer, they can go through the independent match with or without ESIR, do 1 or 2 years independent. All the same options that are available to the current class that matched. They'll have the additional option of matching into the integrated programs directly, in which case they will jump right into the IR pathway. These 3 years will be equivalent to DR 1 through 3, and then they'll be in the IR 4 and IR 5 years. They can internally transfer back to DR. They have some vision that they don't want to do IR, and they could transfer at some point along the way, depending again on some local factors. There's reasons to do it at 2, 3, or 4. The easiest one's probably just wait till they're in R4, since everything should be relatively equivalent up to that point. But we can do it either way. Again, there's some various more subtle differences that make that decision. The VIR fellowships will come to an end. They are going to sunset, as of right now at least, June 30th, 2020. That's the plan. That's what everything's established around. So that's a definite thing that's going to happen. It's mandated by all the powers that be that the fellowships end, and that's the day they're going to end. So you need to have something in place, and you need to have enough front load timeline to build your system up before then, and you think, wow, that's a long way away. But if you look at the timeline, it isn't. So, timeline. The application for the residency will have to do, they're all new programs. They're going to get site revisited. They have to be reviewed and approved by the RRC. They get re-reviewed 2 years from the time of approval. Here's my best attempt at kind of in one slide, which isn't very easy, to show the timeline. So here we are now in 2015. We've got the draft. Actually, we've got it done now. You just matched fellows. We're doing some communication. We've got several RRC meetings. We've got one this June. We've got one in November, January, and April to kind of handle this workload. There'll be applications, site visits, review, approval. There's a subcommittee that's been developed to help us go through all this work. That'll all be happening next year. Next fellow match will be unaffected. I mean, there's nothing that changes for the VIR fellowship match next year. There's nothing that changes for the DR match next year except the knowledge that people will be asking about this. In 2016-17, we should have established the integrated match NRMP, which will occur with the DR match, so it's the same main residency match out of medical school. They'll be able to apply to IR programs, they'll be able to apply to DR programs. There's ways that they can rank lists so that if they don't match into IR and then they can get into DR programs that are kind of second tier, That's a whole nother talk that we still are kind of getting the details on, but that's NRMP, and we're still working with them to figure out how this is all going to work. But ideally, that'll all be established. You'll interview and match people into IR integrated 2016-17 with any program and integrated that's already been approved. That same year will be the last, let's see, is that right? Yeah, the last fellow match will occur that year because those people will be in the 2019-20 year, which will be the last fellowship year. So the last fellow match will occur this year. So by the time 2018 rolls around, we need to have an independent match established for the independent programs. So that will occur in 2017-18. So you can see because of the front load of a 2-year time period or a 1.5-year time period, we need to kind of get moving on things now, and timelines really aren't that long. The end result is very far away, but the front end is actually much closer than you can imagine. So another way just to look at it, I think Kay showed kind of a similar slide to this on the day of reckoning on July 1st, 2020, when no more fellowships will exist. We have to have these other things in place in order for that to be able to happen. As I said earlier, if you're applying for an integrated residency, you can kind of apply for the independent at the same time. We'll kind of put that on hold. Since they won't be active until 2020, we don't need to approve them and have them just sitting out there. We'll have them kind of held for a while, and then we'll re-review them with any updated information and then activate that at the time we need to. And so you have enough time to do what you need to do. You'll only get one site visit for that, for the initial integrated application. We're still working with NRMP for the development of the integrated independent match and the lead time for all of that. The key dates to know now, you need to start talking to your department, your GME, you need to make funding decisions and start on your application if you want to get into the integrated system at its earliest time. 2016-17 is the year we'll be able to establish the integrated match, assuming there's no major hiccups. The last fellowship match will be in 2017-18. We'll probably have the independent match in 2018-19. I put that as probable because it's possible that we would move that into the R4 year instead of the R3 year, which would push it back a year, but that's still up for debate. The last IR fellowship year, 1920. The first independent residence in 2021. And so the end point of all this, when everything stabilizes and everything's kind of done, is actually 2022, 23, or 20, depending on how you count it, 23, 24. So 10 years from now, we'll finally have hopefully a stable environment where we know what everyone's doing at that point. So it's a long timeline, but there's things that have to happen now. But it's a long training period. So, you know, it takes a while to move everyone through the system. Fear. So we've heard a lot of fears. I knew some of these, so I filled out this before I got here, and then since I've been here, I've added a few more fears. This is one of my famous quotes that kind of calms me down before I talk, from Dune. So one of the fears, loss of DR residence to IR, big fear. Uncertainty of interest in IR. Programs without an IR residency somehow being less competitive. Loss of DR resident procedures for the residents to IR. Loss of just procedures in general to the IR community. Are they making a play on trying to take over all types of interventional procedures? Those are all fears I've heard of, and they're all real. So let's face them. So IR residents taking the residency spots. It all depends on your kind of mindset on how you think about this. If you think of your department as a one entity and you've got different slots to put people in, then you really aren't losing anybody. You'll still, if you've got 60 funded positions, 14 residents per year, 4 fellows, that's your situation right now. That's not my situation, by the way. That's someone's situation out there. If you went to an integrated program, potentially only, or an independent as kind of a backup, you could basically match, you could change your match quota over to 1 integrated and 13 DR and just fill that table up over the years as time went on. And at some point, because what you're really trying to do is replace these 4 fellows with 4 trainees in these 2 years to have kind of your IR workforce equivalent to what it was pre-residency. So one of your DR residents may have to internally transfer if you have that person. You could, if you had an independent, you could take somebody into here, but somehow you need to get extra people in here to have the same workforce. But notice, because this is shared year in the PGY 5 year, you actually are under, or you're overfunded by 2 people. You've actually got 2 less bodies than you have funds for because of the shared condition in the PGY 5 year. So it looks like you've lost a ton of DR residents because here's the number of DR residents you have, but really it's this number, 51, plus these 3. So your training capacity in DR is really 54 right now, or your workforce in DR. Your integrated system has 7 people in it, but only 4 of them are really doing full DR training. So you really haven't lost what you think you've lost. You know, you just have to think about it in a different way. But you're still 2 people short. So why did you do that? You shouldn't. You should take more people. So here's the original situation. You can change your match quota and take an extra DR resident every other year and fill up those extra spots. And you'll get back up to your 60. Even if you have one of the 14 that you took this year go over to ESIR, you're still much better off than you would be having this number drop down. So you need to realize that it actually provides you an opportunity to yes, it gets more complicated, but it gives you an opportunity to actually take in more DR residents than what you think you're going to have. It also gives you an opportunity, if you wanted to do it the other way, you could add more IR residents. Say you've got enough DR and you really need more IR workforce. You could take extra people into one of these slots potentially. So you really just need to think about your workforce, your funding, your total funds. All right, I better hurry up. Uncertainty of IR interest. So there's about 200-ish IR fellows that come out each year, 220, 230, depends on kind of how you figure it. Roughly 1,000, give or take, depending on how the match works out. DR residents each year. So none of this is just my assumptions. We have no factual information about what the interest is going to be. But if you figure that of the 200 IR fellows that come out now, not all of them knew they were going to go into IR at the start. And that's not going to suddenly change next year where 200 people know they're going to do IR and all want to go into an integrated program. I mean, I think that's not likely. So what if half of them? We need 100 positions in integrated IR. If half of the people that want to do IR know it from day one and are going to stick with it. And that's a very questionable assumption, but it's possible. You'd then need 100 more positions in the independent world to fill out the rest of that training program. Now, some people believe there's a bigger demand out there, that medical students, there's a whole cadre of medical students that want to do IR that aren't going into it now because DR is the impediment. That may or may not be true. If it's true, we may need more integrated positions. If it's not true, and most people want the flexibility to go back and forth, or decide down the road, then we need more independent positions. So we don't really know what that situation is going to be. We want to provide enough flexibility that those numbers can adjust and individual programs can adjust to what we end up seeing the supply and demand over the next 10 years. Programs without IR residencies are going to be less competitive. Well, 75 to 80% aren't IR. So there's still a huge number of people that absolutely don't want to do IR. As a matter of fact, the less IR they do, they'll be happier. So your program may actually get more competitive because you can give kind of, the minimum amount of IR training to those people. So as long as they're prepared for the boards and things like that and they meet the requirements, you can actually sell that potentially. Some people are going to want to have the freedom to go either way. So they may want to go into a program that has both, but they're not exempted from eventually getting IR training, especially if you have an ESIR. And as a matter of fact, it makes it easy for them to then match to some other location because they want to move or something like that. So there are reasons, again, good and bad. that you can sell or you can tell medical students as to why it's actually still a wholly flexible system that they can do whatever they want to do. What about the procedure lost IR? That training capacity is key. You have to know what that is. You can't bring in more IR trainees than you have capacity to train and hurt the IR residency. It's a requirement that there's enough procedural experience that you don't interfere with the DR training, so you can't cannibalize the training from that. The IR-related rotations allow you some flexibility on your ability to figure out how you want to do your rotations. Not all of them can be in that, but some can. And then my favorite Alan Greenspan quote, so if you understand it, I probably didn't make any sense. All right. And with that, I probably didn't leave enough time for questions, but hopefully that cleared up some of the questions before they get asked. Fire away.
So back to some stuff at the beginning. When do you think the subspecialty program requirements are going to be reviewed? I assume it's going to be after the DR requirements, so that won't be for several years?
Exactly. So as soon as we finish up with the core program, we'll move on to the subspecialty program. So we're, whether it's in a year, we'll start with the kind of requests, or if it'll be like a year and a half, but somewhere in that timeline.
The other question I have is, what's the difference between what I do now? I have a review of the program every year. We make a plan for how we're going to change things. We change them and we document that. What's the difference between that and self-study?
Yeah. So the question is, what's the difference between what you're doing now with your yearly review of the program and what you're going to do in 10 years with the self-study? It's just a more robust form of that in a sense. It's a little more prescribed. Is that correct? Yes. So it has a little bit more constraints as to what you need to do, a little less freedom. Because right now there's really no, there's certain things you're supposed to review, but you don't really have to report on everything. So, but it's very similar. It's just more robust.
Okay, thanks.
Yep.
Hi, Jamal Bukhari from Yale. First of all, are your slides available?
Yes, so the slides will be posted on the ACGME website as soon as we clean up any typo errors.
Excellent, thank you. Secondly, I do have a comment and perhaps three questions. One's on responsibility, timeline, and ESIR. Just for clarification, then, the medical students that are going to come through for interviews in October or November, the integrated pathway choice in the match is not available for them.
Correct. They will not be. There will be no match for the integrated program for this coming year's candidates. Period. There's no way.
And the sunset period for the fellowship, which is the defining time which has been set, if you have 4 fellows now and it's a 2-year program that is substituting for it, it will take 2 years to fill that. So does it mean that the fellowship sunset is over 2 years, or is it over 1 year?
No, so the fellowship so the last fellowship year it'll terminate in June of 2020. And so there's an opportunity to backfill. If the ESIR programs are well established and in place, you essentially will be filling all of your current fellowship positions as a second-year advanced independent position if you have an independent program only. If you have an integrated program, it's a slightly more complex situation, but if you want me to, I can explain that too.
And lastly, for the ESIR, when all is said and done, when everything is in balance, those ESIR residents, when they decide to go out to do their 1 year in IR, are they going to be going into the integrated one or the independent? And if they are going into that independent program, and if it's a standalone independent 2-year program that you've already filled, what positions will be available for them to join a 1-year program?
Right. So it's really important, the complexity of how you fill, particularly because of the 2 year, because we match a whole year in advance for the fellowships and the independent programs. You have to one, it gives you an opportunity to know what you're faced with the next year because you already know what you're getting. But it also makes it a little hard because you have to plan so far in advance. You almost have to, and we're going to provide some grids, some spreadsheet grids that you can kind of look at as examples, and also that you could potentially, I'm working on something that you could actually fill in and it would populate your timeline through 10 years, depending on various choices. But you're right. I mean, if you're full, and you won't be able to match anybody that year. So knowing how many people you take as an ESIR, advanced position, independent position, or if you're taking people for both years, you have to kind of plan that out in advance and look at what's going to happen as those people move through the system. There's no way, unless you're a savant or something, that you can keep track of where everyone is in the system without mapping it out. It's absolutely necessary.
And lastly, we were talking yesterday. Any clarification on the responsibilities of program directors?
So yeah, so it's been clarified. Program director for the DR residency, if they are fully qualified as an IR person, will be able to be the program director of both an integrated program and an integrated IR program and a DR program. There's no ACGME language that prohibits that, so we will allow that. The key, though, is you need to have the time to manage the two programs. It is a bigger responsibility, so we may work into the program requirements when we revise them some kind of scale that determines how much time a program director could get, depending on how much responsibility you have. Technically, they could also be an independent program director at the same time, but that would start to get to be pretty complex. Wouldn't really advise that, but it might work. Who knows? And then you can also assign if you're not the DR program director and you're the IR residency director, you can assign your DR program director as the associate program director and kind of establish their lines of responsibility to be over the residents in those first 3 years when they're largely doing the DR component anyway. So again, you really have to work together. It's really key to making this work, especially if you have an integrated program. Larry?
Jim, thank you very much. That was very, very informative. Only a partially related question to IR.
Yeah.
The thing that scares me a lot as a program director is the self-study and the 10-year site visit coming up.
Yes.
Could you speak a little bit to the roles and responsibilities of the DR program and program director to coordinate the self-study process for the dependent subs? And now here's the IR part of this. What will be the responsibility of the DR program director and program for the self-study for the IR residency? It's a separate residency, but will it all be coordinated as if it was a dependent sub?
Right. So the second part might be easier to answer. I mean, ultimately, the IR program director, whether they're the DR program director or not, are responsible for the entire integrated IR residency experience. They're the ones that sign off on it. They're the ones that have to verify the information's correct. So they're the ones responsible for the self-study for the IR residency as it exists. Absolutely, they are going to have to work extremely closely with the DR program director because much of the information is the same. And there's a ton of overlap. And how you monitor both of those sets of residents, you need to kind of establish. I mean, if you think about it, you won't even really notice, or you shouldn't notice much of a difference during the first 3 years. You just have to say, here's the information we're keeping on the DR residents. It's all the same, but we're going to take this one resident who's actually an IR resident and put them in a different box so that we can keep track of them. And then the IR residency director has to oversee that. But nothing stops the DR program director from basically, establishing all the criteria that they do in the DR portion of it. So by answering the second question, I managed to lose your first question. Subs. Felicia, maybe you can answer that?
So it's sort of the same scenario. The subspecialty program directors are in fact responsible for their own self-study process. However, it should be a close collaborative process between the subspecialty program director and the core program director, in that you're functioning out of the same educational environment. So it's very likely that in doing the self-study process, as you identify strengths and weaknesses in your program, could very much permeate and affect the subspecialties in some way. And in addition, any improvement efforts that you determine at the core program level could permeate and involve the subspecialties as well. So it will be a tightly knit process, but the subspecialty program directors are responsible for their own process.
All right, thanks. Yep.
Hi, Rob Kenningsberg from Hahnemann Drexel. With the ESIR, I know that our program can fulfill practically every requirement that was stated here. The only thing I wanted to call your attention, which I'm sure you've debated already, is that clinical block, which you illustrated in the last block of the 4th year, when I think a number of us don't have the full attention of our residents because they're getting ready to go to their next position. So whether or not there could be some built-in flexibility for that rotation to be declared either in the DR residency or the accepting IR-DR program. I just don't know, even if we offered that block, and I know we can offer that block, that's not a problem, but if that's really the right thing to do.
Yeah, that's a great point, and you're right, we have definitely considered it and debated it. So there's a careful balance here when we built the program requirements between what's been established by, again, the powers that be, the ABR, the ABMS, ACGME, as to what this new residency needs to contain in order to be a new IR robust residency. And the components of that are the increased number of studies, procedures, the increased breadth of procedures, the clinical care. So the ICU, the clinical care, the critical care rotation is a key component in the IR world, and it must be there. So the big debate is, when does that need to occur? And so it basically was decided that it should probably occur whenever possible, at least in the first year of that last 2 years of IR training. It doesn't have to occur at the end. That block diagram, if you know block diagrams, it has no order to it because your residents are going to flip through depending on when. So I put it at the end just because that's the last thing I got to. But it could be anywhere in the timeline of the last year. It could even be in the 3rd year or whenever. I mean, it really doesn't matter when that is. It just
I think the program requirements are pretty clear. It has to be either in the 4th or 5th year.
Yeah.
So I don't think we can debate that at this
right.
point. But I do think it could be up to the program directors to talk about it and then report it to the RRC if it's going to occur in the 5th or 6th year, depending upon the IR-DR accepting program director's preference.
Yeah, I think the problem is the whole point of the ESIR is to establish some uniformity. I mean, there'll still be some variability, but we need some degree of uniformity so that the IR accepting programs know what they're going to get and not have to worry about this resident I'm going to have to add an ICU experience, this resident I'm not going to have to add an ICU experience. So keeping that in the ESIR, it was felt, would make a more uniform experience. I absolutely hear what you're saying, and we've definitely discussed it, but as of right now, at least, that's where we stand on that. So.
Anna Rosenstein, Columbia University. I chair the Matching Plan Committee. And thank you for your exceptionally informative presentation, and also thank you for throwing a lifeline in the time of crisis to the programs that have now applicants who matched and no preliminary positions. And so at least we know now that you will for 1 year exempt our trainees, future trainees, which already have some pre-existing clinical experience. And my colleagues after my presentation asked me whether, for example, you would consider on the RRC level adding flexibility to the clinical training to those in the cases of applicants that have no pre-existing clinical training, but allowing them to start, if possible, earlier, or starting in 16 and introducing clinical training during the training process. So, you know, shifting it a little bit. And so, do you have any thoughts on it?
Sure. Yes, I have thoughts.
Thank you.
No, it's something that we're going to, I mean, it's definitely something that's come up this week. It's brand new information. I mean, it's not new, but it's kind of come to its forefront. There's been lots of different talk that's gone on as far as different ideas. We're going to have to go back and assess that both at the ACGME level and what can be allowed, and at the RRC level is what we'll allow. But we will be discussing various options for that and see if there is any possibility. There may or may not. I'm not promising anything at this point. Is that fair enough, Felicia? All right.
Hi, Trudy Hughes, UCSD. Looking at this from a different point of view, patients want to know three things. Have you done this procedure before? Are you board certified? Have you done a fellowship? How do you answer the last part of that? Have you done a fellowship?
Well, so everyone up through 2020 will have done a fellowship if you're an IR fellowship trained person, and after that, you'll probably there will be a time period where we're going to have to explain that you've done a residency. You've done an interventional residency. The IR residency, it's not DR IR residency, it's an IR DR certificate, but you've done an IR residency for 5 years. Admittedly, some of that component of training is in DR, but you're IR trained. If you're doing the 2-year independent program, you've still done a second residency. It's no different than an internal medicine doc that finishes their internal medicine and goes on and does a cardiology residency. So you can do 2 residencies now and 2 different things and be certified. So it'll be an explanation because the fellowship word will disappear.
I think there'll be some doubt in the patient's mind immediately before they're having an interventional procedure that will cause anxiety.
I have no doubt. I totally hear what you're saying.
Hey, Rachel Oser, UAB Birmingham. So we're putting together our integrated residency right now for IRDR, and we've had some questions about the language for the program coordinators. It says that you're supposed to have, a coordinator, but it doesn't specify that they can't do other stuff. And do we need like a designated person who's just our program coordinator?
Yeah. So there is an FAQ.
With DR?
Oh, sorry. There is an FAQ that addresses that, and the answer in short is yes, as long as they have adequate time and resources, that you could potentially have your DR coordinator be your IR coordinator as well. We'd need to kind of know that, but it's allowed, and there is a little more information on that in the FAQs.
Okay, thank you.
Mm-hmm.
Hey, Jim, that was a great talk.
Thanks.
Ed Donnelly from Vanderbilt. My question is about ESIR. When you apply for that, is that going to be for a certain number of spots, or is that going to be sort of a global certification, and could you have like some, all, or none of your residents in it at any one time?
That's correct. So it's a curriculum, and we won't establish any kind of complement or number value. That is where we'll want to see what you're capable of training, and that's why that's part of the application, so that we're aware as we review your information each year, like if you're starting to put too many people into that compared to what your application said you could basically provide. So, we'd have, there's not a lot of back checking for it, but we'll have some ways to establish whether or not you're kind of overutilizing that. But you could have 0 people in it. You could have 1, 2, however many you can if you have less residents, IR residents for some reason, and you have more interest in people that are in your IR program or in your DR program, you could put more people into your ESIR that year to kind of fill the workforce issues. So it gives you, again, another level of flexibility. Again, depending on kind of how the workforce and the labor force for IR rolls through all this. So that, again, can't state enough how as this rolls out, the more flexibility we have, the better it is for everyone.
And then how late into their residency could they transfer? Like, could they wait until, say, they're in their R3 year and then now they've matched to a place that will let them, could they then at that point say, well, I want to go into the...
Yeah, so once they've like if you have a R3 that matches to an independent residency, they're in their match rules, and if they pulled out of that and stayed in your programs integrated by transferring internally, that would be...
I meant to do the ESIR.
So they could, yeah. So you'd want to establish before they go into the match whether you've accepted them into the ESIR curriculum. So ideally, before they go to the match, you'd sit down with your residents that are interested in ESIR, and you'd say, 3 of my 10 residents want to do ESIR. We can only take 2 because that's all the capacity we have. you have a selection criteria for how those two are selected, and you tell those two they're in ESIR, they have to complete this curriculum in their 4th year, and then they'll be eligible during the match to be the advanced position, and they can tell the programs that are interviewing them that. The other person who doesn't get your ESIR, they basically will have to say when they go through the match that they're not eligible for ESIR, they won't have it, and they won't be able to go into the advanced position, and they're looking for the first of a 2-year position. How that's going to play out is going to be complicated. It's probably the one thing that, you know, until actually numbers start rolling through, it's going to be hard, and there's going to be a lot of angst about that. We'll try and get that more and more explained so that that becomes clear, because we don't want to have residents or medical students fearful of uncertainty, but there's going to be some.
Thanks.
Yep. There is now. I mean, there's always uncertainty.
Hi, Stephanie McCormick, University of Louisville. So for programs such as mine that do not have any fellowships, we have a complement of 20 DR. So does that mean we're kind of stuck in the ESIR? Or if we apply for the integrated or independent, is it going to cannibalize?
All options are open to you.
Okay. If we apply for the independent.
So you're the kind of program that can do nothing. You can apply for ESIR, which probably is advisable. You can, if you think you have the resources and the capacity to train an integrated program, you could transfer, depending on your funding issues, you could either increase or transfer money over to the IR side and establish an IR residency. You don't have to fill every year. You could fill every other year or something like that. So you have all those flexible options. You could add the integrated independent program with that, or you could just apply for the independent program. And if you have interested DR residents, you can put them into ESIR and then match them into your own advanced position, which would be just like a fellowship year. You could give them the ESIR and let them go elsewhere. So yeah, basically, you're the kind of program we wanted to make sure that you weren't put into some box that you can't get out of. So,
so
I mean, every other program has the same options, but with nothing, you can do any of those depending on your resources.
Will our complement then be re-examined, or is the IR component going to cannibalize from the DR component? Well,
that is still something that's slightly being decided as to how we're going to. Will we keep your complement for DR the same, because that is your capacity to train in DR from an ACGME standpoint. So we may leave your complement at 20. That's one potential option. I'm not guaranteeing that. And then you would have if you had an integrated program and you wanted to match one for every year, you'd end up having a complement of 5. You'd have to prove that you had enough training capacity to train essentially 2 fellow type people. But yeah, that's what we're kind of hoping to allow, that flexibility, so you don't have to go in and change your complement all the time, but we're still working through some of those details to see what we're allowed to do and what we're not. Okay?
Hi, I'm Lori Lamassney from Chicago, and I appreciate there's been an intense amount of work that's gone into this process, and you're trying to make it all visible and clear as it can be as it continues to unfold and evolve. I think that your constant word flexibility is killing me, because I don't work in a flexible environment. I'm given X number of residents, and they are defined by their training programs, and so an IRDR resident is in a different program. Having that person transition to my program is really not a flexible activity. If he decides he hates IR, or my IR director says he's terrible, get him out of here, he's got to keep him, because I can't add to my complement. I'm working in an environment of fixed caps, and in fact we're over our caps, so the institution is constantly looking for ways to whittle that down and eliminate and reduce waste or extras. Yeah. So I can't just transition him and telling them that I'm taking a 4-year resident and, oh, he likes IR, now he's a 5-year resident, you have to pay for another year. GME isn't going to pay for that. If we pay for that, that's going to be we, the department. Right. And we can't afford that cost. So now you're telling me there's this individualistic 3rd-year match going on under my nose, so he's applying for DR, IR somewhere else, and now what I planned for my call pool AIRP opportunities, we have a couple of away rotations that we really enjoy, I'm going to have to tell them no because I can't do duty hours and
well, you
get
won't,
the other
you
training.
won't lose your DR resident to that late match. That late match is for after they're finished. They're not leaving your residency to take a different position somewhere else.
But even if he wants to stay in the internal program, now he's 9 months minimum, but it's 9 months when we work on blocks. Okay, so that's not really 9, that's 10 for me. And then I have to do his nukes and MAMs, call, well, I can't do that. The program can't transition on a dime. I have to plan, as you say, years in advance. And when the second years think they're taking X call, and then I say, oh, but he wanted to do IR, he's special, so now he doesn't take that call. I don't have that flexibility. In my GME office, you presented a slide for 60 residents. I've only got 24. Wow. And you presented a slide that said, well, then this is your opportunity to recruit 2 more residents. I don't have a GME committee that's going to pay for that.
Well, you have X number of funds for your residents. You have 20. Do you have any fellows right now?
We have 3 fellows.
And they're paid by?
They're paid by 2 by our department and 1 by GME.
Okay, so you've got 21 funds.
That's 3 fellows total, 1 IR.
1 IR, which is paid by?
The department.
The department. So you still have 20 funds coming from GME. I mean, you just need 20 residents in either IR or DR. Now, your GME office needs to understand that this is really still one thing. I understand. I totally get. I've heard it 1,000 times maybe. That GME offices will say these are 2 separate residencies, and we don't work that way. But they've also never faced this kind of a situation, and they have to understand that there is a way to make it work. If they say no, then you're right. You're stuck. I mean, we hope that isn't going to be the case.
But I think, have you asked
we've developed
people?
a system so that we can work with as many people as we can. If your system just won't let you do it, I mean, there's no undoing the decisions that have already been made. We've made the word flexibility is as a whole, all programs have the ability to kind of work it out in their local environment the best they can. If it doesn't work, and we hope we've developed a system where everyone can make it work, but we can't guarantee that. So, I mean, I'd like to say I guarantee that every program can set some way locally that they can do it, but no system works like that. So I hope it works for you, and we're certainly happy to do as much mentoring and education as we can to make any individual situation work for their institution. But we don't control the institution. So.
Matt DeVries from the University of Nebraska. Thank you for your presentation. Kind of turn the question to the DR certificate. So, and I'm interested with the upcoming reworking of the DR core program requirements. Is there any talk about leveling the DR certificate field in terms of we're giving a DR IR certificate after 3 years of DR, and what IR has decided we need a little more focus, 2 years to actually get the breadth of stuff.
Right.
What about like an MSK fellowship where you actually feel like, hey, we can really teach that in 1 year still? Any thought of, let's say if a person really felt they were going to be a generalist, that you would still have to go through 4 years of the DR, versus if I want to do MSK, maybe I do 3 years of a DR and am able to match into a fellowship structure so that I'm done in 4 years, yet I've done the equivalent amount of work to get that DR certificate as my IR-DR counterpart.
Yeah, I think I understand. So, I mean, it's basically using what's considered the R4 year, and you'd like to transition it to where that becomes more of a true fellowship. They're done with their DR, and they kind of work that. We probably won't be able to shorten to be able to say that someone that hasn't done 4 years of DR training has finished there. I mean, that would be a bigger decision than us.
Well, but I mean, within the IR-DR sense, that's what we've said. We've said that they've done 3 years of DR.
Yeah. And
because where I'm going with this is what happens if these specialties split someday in the future, like RAD-ONC. Okay, so we've got IR-DR, we've got a IR person, we've got our DR residents.
Yep.
They're going to be competing in the same job market.
Right.
Now, I'm a hospital system, I'm a group. Who am I going to hire, right? I've got an IR-DR person who's got kind of a dual certificate versus the DR person. I just wonder if we're going to be kind of an unintended consequence is kind of this second-class citizen that we're putting our DR people into.
Yeah, so I've heard that before. I don't know that I have an answer for it, but I definitely hear that.
Since this is a new program, and I understand Medicare is funding new programs, will we be able to try and pitch that to Medicare in our own state so that this is a brand new program and that's how we can try and get funding? Because I agree with the former speaker, GME offices don't have, most of them are over the cap and they're not funding programs, but Medicare is funding new programs. So do you think we would be able, or do you know if that has been tried or been approached to Medicare to say this is a brand new program, so we're going to add so many residents throughout the country and we can try that method to fund these positions?
I don't think I have the expertise to answer that question.
I mean, I think
it's a great idea if it works. I just have no idea whether or not that's something we can do. But if there's funding available, I don't see why you wouldn't go after it.
Medicare is funding a new residency program.
Yeah, it's a new residency program. I mean, that's all there is to it.
But nobody's spoken about it, and I wonder why not. That's what I'm trying to ask.
Yeah, I don't speak about it because it's not in the ACGME purview. So we don't control funding, which is, again, why we've thought about all of everyone's funding issues, but every place has slightly different situations. Some are over the cap, some are under the cap, some are limited, some are paying for their own. I mean, there's as many different funding solutions as there are programs out there, and depending on how well your GME office knows the situation is going to determine whether or not they easily approve this, or hopefully, even under the difficult situations, that they will understand it and allow you to do this. But it's something we just can't accommodate for. We've tried to build in as much flexibility so that you can design it in a way that will work within your system. All right. We're way over, they said. Okay. All right. Well, thank you.